Recording in progress.
Okay, it looks like everyone is on. We still have jumping in, making sure everyone has audio before we start.
Testing, can you hear me fine? This is Sergeant Christensen.
Yes, Sergeant, we can hear you just fine. And thank you to the rest of you for muting if you're not speaking. And I believe we have everyone on and connected to audio. So let's go ahead and get started. I'm going to call this meeting to order. And if we could start with roll call, please.
Okay, sorry, I had to let more people in. Dina Flores O'Toole.
Here.
Shayla Holmes.
Present.
Christine Payson.
Present.
Dr. Terry Kearns. Jill Tolles.
Present.
Dr. Stephanie Woodard.
Present.
We have a quorum. And Dr. Kearns had let us know she wouldn't be able to attend.
Wonderful, thank you so much. So then welcome everyone. Glad that you could join us on this chilly spring day, and I'm looking forward very much to the agenda that we have today. So I'd like to start with public comment. Do we have anyone here who is, let's start with on Zoom here to provide public comment on Zoom, and then we'll go to the telephone. If you just want to, I don't see any hands raised. Okay, so seeing no hands raised for Zoom, if we could turn to the phone lines. Is there anyone on the phone lines who'd like to provide public comment, with the reminder that we're limited to 3 minutes per person and no action will be taken on public comment? Anyone on the lines? Crystal?
I don't see anyone coming off of mute. We do have people joining only by phone, it looks like. But I haven't heard anyone.
Okay, if you'd like to unmute if you plan on making any public comment. I don't see anything visually or anything, any hands raised. We'll give it just another 10 seconds. If anyone wants to unmute and make public comment, now's your chance. Okay, hearing no public comment. And if you are not speaking, if you could please mute your microphone, that would be helpful, just to eliminate any background noise. Thank you so much. So the next item on our agenda is to approve the minutes from our last subcommittee meeting for the response subcommittee on April 11th, 2022. And I will open it up for any comments, questions, or proposed amendments to the minutes. And again, you can use the hand raising, or if I don't happen to see your hand raised, you can please unmute yourself and speak up. Okay, I don't see any hands raised. I don't hear anyone speaking up. If you are on and you're able to turn your video on, we'd love to see your smiling faces. If you're waiting until it's your turn and you're finishing your lunch, we completely understand. Just nice to look at more than just myself when I'm addressing everyone in the room, in the virtual room. So with that, with no comments, can I take a motion to approve the minutes from April 11th, 2022?
Stephanie Woodard for the record, so moved.
Thank you, Dr. Woodard. So we have a motion from Dr. Woodard. Do we have a second?
I'll second that. Gina Flores O'Toole.
Thank you, Ms. Flores O'Toole. So we have a second. And then all in favor, please unmute your microphone, say aye.
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 Any opposed? Say nay. Okay. Hearing all ayes, no nays, minutes are approved unanimously. So moving on to, just clipping right along here, moving on to the tickets that we all purchased for admission here to hear from our guest speakers. Today, one of the first things that we identified as a subcommittee in regards to response was wanting to hear from our local law enforcement agencies. This subcommittee and this working group as a whole has been charged with the task of coming up with recommendations for all, including policy changes potentially to our NRS statute, to budgetary requests, either from state funding, federal funding, or the use of the opioid settlement dollars, and then any other actions that we identify that we can make recommendations to take as a state that do not fall into the policy or budget categories. And in the response subcommittee working group, we're looking at all levels of response to substance use issues in our state and individuals' lives, families, and communities that are impacted. And we wanted to hear from local law enforcement to understand better the scope of the issues that they're seeing from their perspective in their communities and jurisdictions, taking a look at everything from the types of substances that they're identifying, the arrests, statistics, issues of co-occurring disorders with mental health and perhaps domestic violence, other impacts on our community, economic, social, and crime-related information. And so we're looking forward to a series of presentations today to hear how this issue is impacting our criminal justice system at the jurisdictional level, and then hopefully to ask questions as subcommittee members with the idea in mind to my fellow members that we are looking for what kind of recommendations we may make as from these informational presentations from our subject matter experts today. So with that long introduction of casting my vision for this agenda today, I'd like to start off with, and I apologize, let me get back on my screen here, to our first presenter. If we can click the slide, I believe that the first person that we are going to be kicking off to is, and please correct me if I'm wrong, Christine Payson.
Thank you. Just to be clear, you'll be clicking the slides for me as I tell you to advance. Is that correct?
Yes, Christine, I can do that.
Okay, great. Okay, so I'm Christine Payson. I'm the Drug Intelligence Officer for Nevada HIDA, and I don't think she's on yet, but we hopefully will be joined by the manager of our Investigative Support Center, Kimber Davis, just in case there's any data questions that might come up from some of the things I cover. Next slide. And don't have any disclosures, so no issues there. Next slide. So I'm going to cover some things that are going on currently in Nevada, specifically Southern Nevada. Just highlight them and let you know what's working well, where we're finding some gaps, and where we could use some improvement. And then we'll go into recommendations. So I'm going to cover these topics here. The LIMA is Law Enforcement Intervention for Mental Health and Addiction. There's a homeless outreach. CIT is our crisis intervention team. ORT is overdose response team that responds to the actual scenes of overdoses and it does the investigation. I'm going to highlight some of the school and community outreach that's been going on, and then finally give a brief idea of the HIDA and ORS, or Overdose Response Strategy, which is a collaboration between public health and public safety. Next slide. So I put this one up front, the special populations. We all know about the special populations that we want to focus on, and I'm hoping by just kind of putting that out front, you'll see that as I cover each of these items, that these units and these special teams do in fact cover most, if not all, of these populations in some way. Next slide. So the first one I mentioned, like I said, is the Law Enforcement Intervention for Mental Health and Addiction. And this is a team of officers that when they come into contact with low-level nonviolent offenders, we'll give them an option of connecting to resources and treatment rather than incarceration. So if they choose to take advantage of that, then they get them connected with the proper treatment program. And what the charges are held in abeyance. And if they complete the program, then the charges are dismissed. So it's a 9 to 12 month, like I said, pre-booking diversion. And again, low-level, nonviolent offenders. And these officers go out and make contact, and then they have a list of resources within the community that they work with to get them not only treatment, but other social services that they may need. And the whole goal is to divert eligible individuals to services, and that in the end improves public safety and reduces crime. Next slide. So HOT team, we love our acronyms. So the HOT team is the Homeless Outreach Team, and this is a group of officers with special knowledge and resources that isn't readily available to all the regular patrol officers. And they have the goal of bringing the resources, again, similar to Lima, but specifically to unhoused citizens within Clark County. So it's a newer approach that Las Vegas Metro has implemented, and it's an effort to lower the number of unhoused individuals requiring law enforcement or medical response. And then if they come in contact with someone who would be a good fit for the Lima program from the previous slide, then they'll go ahead and make that referral as well. Next slide. And our crisis intervention team, again, this is a group of officers with specialized training that the everyday patrol officer might not have, and they are trained to show up on scenes where persons are in crisis and provide direction and guidance to the officers and the family and of the individuals that are in crisis, or persons showing signs of excited delirium, persons who are believed to have a mental illness, or persons with a developmental disability. So these officers go in, and the whole goal is de-escalation with care and referral to proper services, whatever they may need. And again, if it's a good fit for the Lima program, then the CIT officers will do that referral as well. Next slide. The overdose response team. These are the detectives that actually show up to a fatal or a non-fatal overdose and start developing investigative leads and identifying the drug sellers and traffickers that are responsible for creating the deadly situation. So we want to go after the source of supply. Where is this coming from? And that team has 4 fundamental elements that form their strategy, which are creating a cross-disciplinary collaboration between public health and public safety at federal, state, and local levels, reducing the drug availability, preventing the drug overdose, and making treatment and recovery available to the victims and the families that are impacted by those overdoses. Unfortunately, there's one team currently in Las Vegas, and they are very busy. So they had to develop a triage system on how they'll handle the cases and which ones will get most of their time and effort. So a tier 1 would be a case where there's the most probability for a successful prosecution, tier 2 with limited probability of success, and then tier 3, there's little or no probability of being able to have a successful prosecution, so that one won't get as much time. Next slide. I mentioned some school and community outreach that's been done with Nevada HIDA personnel and local law enforcement. they've done several school presentations already, and those were done pretty quickly, kind of off the cuff, put together in response to requests from schools that had children who actually had overdosed. So now we're working with the PACT Coalition and the school district on getting a more formalized and cohesive school presentation put together so that the same message is going out to each school. So we just want to get that formalized, and we're finding the best way through the school district on how to share that information with the schools. We're looking at developing a teach the teacher version of this, because there's no way we could get to all the schools. So if we can train the trainer, then we can reach more students. And just today, the 4 15-second videos that are mentioned on the slide were released, and it was a press release, and they're aimed at targeting our younger audiences and warning them specifically of the dangers of fentanyl. So it says not finalized yet, but that was before when I sent off the slides, and it did come out today with a press release. And so they're broken into age groups. The younger groups are going to have a little bit more of an upbeat message, and then as they get to the older kids, it's definitely a more sobering message on the dangers of fentanyl. And the whole idea with this is we wanted to be proactive rather than reactive. Even though the first couple presentations were reactive to specific overdoses, now we're trying to get out there in front of it. And they're also developing a campaign through social media, targeting the social media, things like Snapchat, because we know that's where youth are connecting with dealers and making purchases. So it should look almost like a pop-up ad where they're kind of outing the dealers and warning the youth about who they're talking to. So that's still in the works. I'm not a tech person, but that's how it was explained to me, that it would work almost like a pop-up ad. Next slide. The partnership I mentioned, HIDA, is the High Intensity Drug Trafficking Area, and that was created in 1988. And it coordinates and assists federal, state, local, and tribal law enforcement agencies to address regional drug threats with the purpose of reducing drug trafficking and drug production in the United States. And then more recently, the Overdose Response Strategy, which is part of HIDA, is really an unprecedented and unique collaboration between public health and public safety. And it's created to help local communities reduce drug overdoses and save lives by sharing timely data, pertinent intelligence, and innovative strategies. Did we go to the next slide? I wasn't looking. Yes, we did. Thank you. Okay, so ORS, or the Overdose Response Strategy, that's funded by the Office of National Drug Control Policy and the Centers for Disease Control. And again, the mission is to help communities reduce fatal and non-fatal overdoses, and connecting that public health, public safety information relationship. So that's made up of a drug intelligence officer like myself, and I'm paired with a public health analyst. In Nevada, it's Lacey Alderson. And these teams are throughout the U.S. Every state has at least one team of a drug intelligence officer and a PHA. Some of the bigger states have several teams, and they're also in Puerto Rico and the Virgin Islands. And this nationwide network is constantly in contact with each other, sharing information, sharing data, sharing what we're seeing in our area of responsibility, and so whether it's a novel substance, a new color mixed in with fentanyl, whatever it is, we're constantly sharing that information with each other and with our public health partners. Next slide. So of all those things that I covered, what's working well, the LEMA program, the diversion, is going well. They've had several graduations, and they report high success with very low recidivism for the people that make it through that program. Our overdose response team is putting together solid cases for prosecution and eliminating the source of supply and bringing some awareness to the community, offenders, and the people who use drugs. A lot of times, narcotics cases don't make big news, but when you start charging someone with murder, it starts sparking some conversation, whether it's at school, between parents and kids. So they're doing a lot of good work out there, but they are just one team. So like everybody, they're short-staffed and they would like more. Another thing that's going well is OD MAP. Dr. Kearns, of course, is heading that up, but just to clarify, it's a nationwide syndromic surveillance tool that provides near real-time suspected overdose data, and it links information from the first responders and relevant record managed systems to a mapping tool, which tracks overdoses to promote real-time response and strategic analysis across jurisdiction. And what's working well in Nevada is we have been one of the only states that has every county represented in the OD map system. So we're happy with that. Next slide. Again, the homeless outreach teams and the crisis intervention teams are out there making contact, getting services to people who need them, and trying to keep people out of the criminal justice system if it's really something that's due to illness-related behaviors. So they do have their challenges. The homeless outreach team is made up of 6 officers and 1 sergeant for the entire valley, and the crisis intervention team, there are 4 officers that have this training currently for the entire valley. So they are extremely busy, and like again, everybody would like more bodies to do more good things. Next slide. So I've got up here as a gap. This is the actual response criteria for the overdose response team to show up at an overdose. There's simply no way they could possibly make it to all scenes. So they will go if there is a fatal involving 2 or more persons, or if a fatal overdose is linked to another fatal overdose incident previously. They'll go if it's a non-fatal involving 2 or more persons, or when any of these 4 things also exist, and that being a physical substance present, a witness to the overdose, telephonic or electronic evidence of contact with a source of supply, or if 1 or more victims wishes to cooperate. And finally, they'll also respond if there's a substantial amount of heroin or fentanyl present, counterfeit pills, or there's some other evidence to suggest that immediate action can be taken to identify the drug supplier. And so with that, like I said, they can't get to them all. So we hope that maybe by expanding, that maybe they can expand their response criteria as well. Next slide. Another gap is in reference to AB 236, and while we know the intent was to address Nevada's growing prison population and the expense that goes with that, it didn't consider the public safety threat stemming from the increased weights involving deadlier drugs, specifically like fentanyl, that are being trafficked in the community, and the impact to the overdose victims and their families. So because it doesn't separate drugs like fentanyl from other drugs like heroin, methamphetamine, or cocaine. And since we can see here that according to the DEA, it only takes 2 milligrams that can be a lethal dose of fentanyl, and under AB 236, a dealer would need to be found with this next slide. I'll show you the penalties and the weights that they need to be found with. So you can see here in the red the lethality as it relates to fentanyl. So with the prior law, if you had less than 14 grams, or less than 4 grams, you were considered low-level trafficking, and now you need to have less than 14, and then it's just a referral. But that's enough fentanyl to kill 6,995 people. And as you go up in the amounts, you can see comparing it to the prior law for mid-level trafficking, it has now gone up from 4 to 28 to 14 to 28, which could result in 1 to 4 years, but that amount of fentanyl can kill 13,995 people. And as you can see, they continue to go up all the way to greater than 42 grams, but less than 100. The penalty is only 2 to 15 years, but the potential to kill is almost 50,000 people. So we feel like an amendment to that bill to separate fentanyl out with steeper penalties would be appropriate. Next slide. So here are our recommendations. I covered a little bit on the AB 236, but also reference to the overdose response team and investigating the source of supply. We'd like to see some funding for an independent medical examiner that can provide a report to verify the specific cause of death in an overdose case, once the source of the drug supply has been identified and can be prosecuted. These are very expensive reports, and the DAs are wanting these causation experts to provide reports before they'll go forward with prosecution, particularly in cases where there are polydrugs in the victim system, which is most of the time. We'd like to see possibility of funding for an API for the ODMAP system. This is an application program interface, which basically allows the software, regardless of what first responder agency's software is, they can talk to each other and enter into ODMAP. It's currently being grant funded, but that's going to end at the end of the year, and to my knowledge, there has not been any new funding identified for that, so perhaps we can look at some funding for the ODMAP API. And again, I covered all of those teams out there: overdose response, CIT, homeless outreach, Lima. They're all very short-staffed, so any way we could find a way to add more bodies to these teams that are out there trying to make a difference and keep people out of incarceration and into treatment, we hope that would be something that we can look at. If agencies have them in place, great, we can expand them. And for some of the smaller, more rural areas that perhaps don't have the luxury of teams like this, maybe we can get them implemented. And then again, just because of the increase in fentanyl-related overdose deaths and seizures in Nevada, we feel an amendment to 236 should be implemented, and a lengthier prison sentence to dealers that sell fentanyl, and separate that out. Not all drugs should be treated equal. Next slide. There's my contact information, and I'm happy to answer any questions that I can for you.
Thank you so much for that information. And there's a lot to follow up on and unpack there, but I'd like to open it up to the subcommittee members. I know I have a series of questions. I want to hear what other questions our members have, keeping in mind that this may inform recommendations our subcommittee makes to the whole working group. If you want to raise your hands. Yes, Dr. Woodard.
Thank you, Chair. Christine, I wanted to thank you so much for your presentation this afternoon and recommendations that are being made. Recently, there was actually a significant amount of fentanyl that was confiscated in Alameda County, upwards of 92 pounds. And when that calculation to 2 milligrams per lethal dose was conducted, it was found to have some very significant implications. So really interested in learning more about what potential amendment language could be used for AB 236. But one of the questions that I had was, one of the things that we are hearing, and I'm just wondering if there's been anything that you have seen from a HIDA perspective on the implications of the overdose response teams and some of what we're hearing, the chilling impacts that it can have on the Good Samaritan law. Specifically, if there is an individual present that is witnessing an overdose and they contact law enforcement, and it looks like there could be fatal or non-fatal overdoses that the overdose response team is responding to, that then there are family members or loved ones who may have been using along with the individual who experienced an overdose that are then brought up on prosecution. So I was just wondering if this is something that you have heard of, and if there's been any consideration from a policy perspective on how we can kind of balance both the Good Samaritan law and making sure that people feel safe in being able to contact law enforcement or 911 in the event of an overdose, and then the potential implications that teams like the overdose response team could have.
Okay. you broke a little bit, but I think I understand your question is how are we going to make sure that the Good Samaritan law is followed and subjects who are on scene who may also have been using aren't brought up on additional charges. To my understanding, that is the way it's written, and it's if you are the person that makes the call or if you are the person that the call was made for, then the Good Samaritan law goes into effect in those charges. It's not a free pass. So if you have other criminal behavior going on that's not necessarily related to the overdose, then no, the Good Samaritan law is not going to give you a free get out of jail card. But for instance, there was an overdose of a teacher up north. Was it in Reno or Washoe? But he was brought back with Narcan and was combative and was eventually booked on a variety of charges. And I think, I'm not positive of all the details, I think he may have still had some of the substance on him. So they initially brought the charges, but the DA dismissed them specifically because of the Good Samaritan law. Does that answer your question?
And if I may cut in, if you allow me, Dr. Woodard, I know there's a lot of interest in this particular subject and interaction, and we've actually scheduled some time in August to specifically do a deeper dive into the interaction between the Good Samaritan law and our efforts to crack down on trafficking.
Just Christine, again, if I could just add something, we definitely need the deeper dive once these questions were brought up because, well, charges were initially brought in the first place. They were dropped, but again, like you're saying, that's sending a message that might make people afraid to make the call. And I was recently at the RX Summit in Atlanta and sat in on several sessions for first responders, and this was brought up again, and the answer for one state, I don't even remember what state it was, is, well, they use discretion. And so I thought, that's not good enough. We can't just have random officer discretion on whether or not we're going to implement or go tacking on extra charges. It'd be nice if everybody had the same idea of what discretion is. So yes, a deeper dive and some more clarification is needed.
Thank you for that. Dr. Woodard, did you have any other questions before I open it up to other members? And we do have 2 more presentations to go through.
No, thank you, Chair.
Okay, thank you. Anyone else? Any other subcommittee members have questions? Okay, well, I could stay here all day with questions because I appreciate that there's so many different facets to this. Let me just point out a few things. If I understand the recommendation, and this is a follow-up to Dr. Woodard's question in regards to specific language, as I read your recommendation regarding any changes to the fentanyl limits, the recommendation officially of the DEA, as I understand it, is to lower to the previous law standards, which, just to be clear for the record, so as of right now, the standard in statute is that is as outlined in the gaps on AB 263's slide, that less than 14 grams is a deferral, greater than 14 but less than 28 grams is 1 to 4 years, greater than 28 grams and less than 42 grams is 1 to 10 years, and greater than 42 grams but less than 100 grams is 2 to 15 years. And then I just want to point out that you have the prior law on that slide. So it is the official recommendation of the DEA that we would return to the previous standards for deferral, 1 to 4 years, 1 to 10 years, and 2 to 15 years of fentanyl in particular. Is that correct?
That I cannot say because I can't speak for the DEA. I went with the previous slide, which shows what DEA says is generally a lethal dose, but I can't say that the DEA recommends these changes. This is just conversations that I've had with local law enforcement.
Okay. Well, we would definitely love to get some specific language and recommendations, so that could be something that perhaps our subcommittee could consider in our recommendations and to make to the entire working group. So if we can have some follow-up on that, we would be very interested. I think I have two more just quick questions, and I think they would be for follow-up. One is in regards to the HIDA's regional drug threats. Is there a place where we can learn more about what are some of the trends that HIDA is seeing in regards to regional, national? You mentioned even some international partners, where we're seeing these drug threats. What are some of the trends? How many arrests are we seeing per year and so forth? Is there how many of our crimes are drug related? Whether they're property crimes, or again, how many arrests of traffickers are we seeing? Is there a link to a site where we could on our own do deeper dive of that data and then also make that available is that made available for the public?
I can definitely get the link for the overdose response strategy website, which has a lot of information. But what I will also do is clear with my director, because Nevada HIDA, well, all HIDAs, but do an annual threat assessment. But the Nevada HIDA does a law enforcement sensitive version, but they also do an FOUO version, and I can clear it with him and then get that site up so folks can actually look and see the whole threat assessment.
Wonderful, thank you. And if maybe we can make a note in the minutes to make that information available in the next subcommittee meeting, so that any of the public that's following along, we can make sure that they have access to any publicly available links as well. And I just also wanted to add to that those school links, the educational outreach links that you had talked about, that the press release just went out today. If you could also present that to our subcommittee, I'd love to take a look at those videos. And I know that the prevention subcommittee would also probably be very interested in seeing the links to those videos as well. So we could perhaps share that with the whole working group and reference it in our next meeting for the public. And then the last thing I wanted to dive into is, you said that we have one team, and the overdose response team. How many members on that team? How many full-time and part-time officers do we have on that team? And how does that, do we have any comparisons to other jurisdictions? As we know, Nevada is a tourism-based state, so we're not just dealing with our population that are residents here, but also millions of tourists coming to visit. And do we have any kind of comparables of how many we have on our team as compared to other similar jurisdictions that see our kinds of population, to give us a reference of how staffed or understaffed are we?
I don't know for sure. I think it's definitely one sergeant and either 4 to 6 detectives, but I can get you the exact numbers on that. And how we compare nationally, I'm not sure. I know some states have them, some don't, but what their actual manpower numbers, I do not know.
I would be very curious to see how we're doing, because we certainly have a unique environment where we have high traffic areas. Any other questions for our presenter and subcommittee member, I might point out? I don't see any, so thank you so much, Ms. Payson. Really appreciate you putting this together and your help with this portion of the subcommittee and serving on it. All right, I would like to move on to our next presenters. If we can get that back lined up, we've got Sergeant Christensen, I believe, and Sergeant Walker, who are planning on going next. Is that correct, Crystal?
That's correct. I don't have a PowerPoint for them, but Sergeant Christensen, if you have something you want to share, you should be able to do so.
Excellent. Actually, it's going to be a larger group because I have Sergeant Walker is currently with two of my DSU deputies Mark Kester and Ray Kester. And Deputy Mark Kester was nice enough to go through and organize ultimately what we're looking for, what you guys may be looking for in the subcommittee. So I'm going to give it over to him, and he can kind of start and give you basically a brief rundown of what the Detention Services Unit offers at the Washoe County Sheriff's Office and some of the other areas that we work with, and see if there's ways we can kind of work on that partnership as well.
Thank you, sir. Can you guys hear me okay? Perfect.
I can hear you just fine, Mark.
Sorry, if you could just
about
make
our
sure for the
video,
sake of
we
our
were-
minutes to
we were having-
identify yourself every time you speak, that would be helpful.
Sorry about that. This is Deputy Mark Kester. I apologize about the video. We were having some technical difficulties. Our sound bar wasn't picking up our camera. So as Sergeant Christensen was saying, I'm currently assigned to our Detention Services Unit here at the Washoe County Jail. So just a little bit of a background on us. The Detention Services Unit was established to help and assist our vulnerable population and individuals at high risk of recidivating. This includes individuals suffering from both substance use disorder, homelessness, and mental health. Both the Detention Services and our previously established Inmate Assistance Program work with individuals whether they are court-ordered or not in court-ordered to treatment. This may be through the specialty court, which could be the medication-assisted treatment court, a drug court, adult drug court, or mental health court, for some examples. We work with both the municipal courts, the justice courts, parole and probations, basically anybody who may be involved in the justice system to provide them resources and referrals into the community. Prior to Detention Services and the Inmate Assistance Program, we primarily worked with individuals that were court-ordered. When the DSU started, we started also working with individuals that are under sentence at the jail. So it didn't just have to be individuals that were ordered to court-ordered to treatment, but also to individuals that just wanted to receive case management prior to being released back into the community. Both the Detention Services Unit and the Inmate Assistance Program coordinate with community providers. This is to include inpatient, outpatient, residential, and transitional living programs. And then upon approval, transport those individuals directly to the program so that there's no gaps in treatment or care from when they are released from our custody and ultimately transported to the program. We do work in reading through some of the other slides as far as our special populations. We work with veterans population regularly. We actually have a veterans officer that is assigned to our vet unit that is able to provide specific resources to individuals that are veterans in the military service. We also work with individuals that are taken as a priority to certain programs based on if they inject drugs or if they're pregnant, they're actually taken as a priority. Currently, our jail is an opioid treatment program. We're actually certified as an OTP, and we offer medication-assisted treatment for individuals that can be inducted while in our care and custody. We're able to continue people who are receiving MAT treatment within the community and provide the same MAT services while they're here. That's to include case management, discharge planning, and also therapy and counseling sessions. Let's see here. We try to address this as a wraparound approach rather than just assisting individuals that are suffering from substance abuse, but also from mental health, because we see a lot of the co-occurring dependencies as well as homelessness. So upon discharge from our care and custody, we try to not only get them mental health services, substance abuse services, but then potentially also housing as well through either transitional living or with our Medicaid providers. We have an individual that is on site that is a welfare representative that is able to coordinate with the MCOs and actually get them signed up for Medicaid benefits prior to leaving our custody. So that's just a little bit of a brief rundown on what the Detention Services Unit provides to the individuals that are here currently in our jail and how we can assist them to best transition them back to our community, because ultimately they are community members that are at some point going to return. So we try to give them the best chance and opportunity to prevent them from coming back into our custody by providing those resources and services. Yeah, some of the issues that we've seen just going through our numbers is the mental health population, even through COVID, while our population had decreased, currently our average daily population is around 1,200. Even when our numbers dropped due to COVID, our mental health population continued to rise. Currently, we have close to 50% of our population is receiving some kind of mental health services, psychotropic medication, or being seen by our mental health providers that are currently in our custody. Some of the other issues that we've run into is the long-term continuation of care once they are discharged from our facility. So the mental health services for like long-term housing, long-term assistance, long-term case management, once they ultimately leave here, because once we are able to get them engaged in treatment and services, because we are a secure, safe, lockdown facility that provides all those services, they may not necessarily willingly engage in those services once they're then transitioned back to the community.
And Madam Chair, Sergeant Jason Walker here. One thing I wanted to just touch on is, and it relates to Christine Payson's presentation regarding fentanyl and stuff like that. We are still getting fentanyl introduction into the secure portion of the facility. Just this last quarter, we've had 4 overdose incidents, one being fatal. As far as our protocol standards and procedures, when legally supported, unclosed searches are body scans are conducted on inmates prior to housings. We have protocols in place for decontamination of cells, and clothing have been adopted for inmate and staff safety as well. Naloxone is available throughout the facility, and staff are trained in its application. You know, I agree with Christine is that we need to recommend some amendments to AB 236. I think we are on track for hopefully some modifications in that, but it's a dangerous drug that's out there. You know, our presentation was mainly based on the detention staff or the detention setting with the services unit, inmate assistance program, preventing the recidivism. I just wanted to touch on that one point. Sergeant Christensen, did you have anything to add from DSU on your end?
Yeah, just recently, been working a lot with Morgan Green lately with the state opioid response grant and so on. And we're actually going to provide some fentanyl test strips to inmates at their request, along with the Narcan naloxone that they can request. So we're hoping that that action might be able to help prevent even some of the overdoses out in the community. If those are still suffering from substance abuse, are reintroduced to the population and potentially re-exposed to, you know, different types of drugs that they may have thought didn't possess fentanyl in them. At least this way they have the option to potentially test those as well. So hopefully that can maybe stem off some of the, you know, effects we're having out in our community by the people that unfortunately still suffer from substance abuse disorder and are potentially going to use it when they leave our facility. I do want to give a lot of credit to our medication assisted treatment team that we have. They work diligently with trying to not only induct new clients within the MAT program, but also try to get good referrals so they can continue to receive the kind of treatment to hopefully keep opioids out of their life and improve their quality of life as they move on. It's been relatively successful. I don't have the data to give you the statistics on it, which is something that we can provide at a later date. We can do some research to get you guys some numbers to put in there. We are trying to track it, but it is a fairly new program. It's been going on for a little over a year and a half, but that I want to say has led to a lot of different ways that we can hopefully stem off the effects of this throughout, not just the folks coming into the jail, but also reintroducing them to the community.
Thank you. Does that conclude your presentation?
Yes.
Want to make sure that we gave everyone a chance to to contribute. Thank you for that information and for the willingness to share additional data as it becomes available. Let me open it up to our subcommittee members. Do we have specific questions? And remember, members, these questions are not just only for your benefit, but also for the benefit of the public who's viewing and for building our record in the things that we discuss. So even though sometimes you might know the answer already because you are in this field, don't be shy about asking questions of our presenters and our subject matter experts, because we're essentially mapping out this issue and what we as a subcommittee can bring forward as well-founded recommendations. So I have Dr. Stephanie Woodard, who is ready to ask some questions. The floor is yours.
Thank you, Chair. And thank you, Sergeant Christensen and Officer Kester for your presentation today. Want to applaud Washoe County Detention Center in establishing their opioid treatment program. Really demonstrates some innovation and leadership in making sure that we're getting quality treatment and programming to those who are incarcerated who have an opioid use disorder. Looking forward to seeing some of that data, particularly interested in looking to see the conversion from withdrawal management only to induction and what that induction looks like then to bridge to services out in the community. And also curious to know if you are collecting information as it relates to recidivism and if you've seen an impact on reincarceration for those individuals who have engaged in the OTP treatment services, as well as any information that you may be gathering to determine if those individuals have successfully not only just been referred to treatment, but have reached a stage of maintenance for treatment as well. And then, Chair, if I may, one specific question. Can you talk a little bit about what the services look like that you are transporting to for those who voluntarily enter into services around reentry and how those services are being paid for currently?
Yeah, Sarge, did you want me to take that, sir?
Yeah, you or Ray. I mean, Ray works with the inmate assistant program. So either one of you, if you can give a little bit more information, you both work with those programs and frequently visit them. So the floor is yours, Mark.
I'll go first, sir, Mark Kester, and then Ray Kester will take over for the inmate assistant side. We go based off of, if an individual is court ordered, we'll look at the drug and alcohol assessment to determine if they're requiring inpatient or outpatient services. If the individual is court ordered, we go off the court recommendation first and what both the DA and the public defenders will come into agreement with as far as which programs they're eligible for. Some of the inpatient programs that the courts are working with would be Bridge House, Bristol Cone, Vitality, whether that be in Elko or Carson City, and New Frontier, which is out in Fallon. If the courts are good with outpatient services or transitional housing, we'll work with Battleborn, Crossroads, Life Change, trying to think of the other ones off the top of my head. Bridge House, because they can be both. Basically, once the individual is approved, there are some criteria that we have to look at, whether it be criminal history, crimes of violence, sex offenses, things like that. They may be disqualifying factors, not because of the individual being in our facility, but just because of what the programs will and won't accept. Once the individual is approved, we will actually use either grant funding through the programs or use Medicaid. A lot of the Medicaid MCOs will pay for certain treatment and transitional living, and we will then transport them directly to the program upon approval. The courts kind of leave it up to us. It's been great working with the specialty courts and our judges, where they'll actually give the individual a judge OR or a judge release upon the person being accepted and then transported to the program. So it gives us ample time and opportunity to actually transition them from our facility to the program. For the individuals that are not court ordered and they're just wanting a program upon release, the process is relatively the same. However, we work in conjunction with their time served date as well as the program's bed availability. Even in some cases, individuals we have in custody have what we call good time work time, which is time that is given to them based on their sentence structure. And in some cases, we'll actually have individuals give that time back to us and say, I would rather stay in jail 3 days longer, 4 days longer, 5 days longer, specifically so you can get me to this program and transport me there. So we are able to work with the release dates as well as work with people that are being released from custody based on the bed availability at the programs.
This is Deputy Ray Kester. As Mark was saying, the programs are paid through Medicaid, but some of the programs that will take them as far as transitional housing do have a cost that's attached to them. They do charge a rent for their stay and their programming, but they also connect them with jobs that can pay such a cost. They do a sliding scale based on how much they make and what they're receiving in the programs. I've been doing the court-ordered version of this office for about 7 years. It's worked very well. When they're court-ordered, they're kind of forced to go to a program, so they're less likely to walk out. The DSU side, though, we're seeing a lot of changes because the opioid problem is such an issue, and the users see how dangerous it is, so they're actually reaching out. And through DSU, we can build a rapport with the clients and actually walk them through it. And once they leave the jail, they're still requesting to talk to us and to continue services with this office.
Yeah, Deputy Mark Kester again, just to give you an idea of how many people we're working with monthly, and just doing a quick add up of some of our stats month to month. Between the specialty courts, IAP, and self-referrals, we're getting and working with anywhere from 50 to 80 people per month. That's people that we're transitioning out of custody and ultimately taking to programs. So we're working with a significant number of, when we're close to 50 or 80 of a 1,200 people population, and we have 5 deputies that are assigned to do that. It's a fairly hefty workload.
Yes, I can imagine. Thank you for that. Dr. Woodard, I see your hand is lowered. I assume that you're done with all your questions. And Ms. Flores O'Toole, I see your hand raised if you'd like to ask your questions.
Sure. Sergeant, I was wondering if you could talk about some of the barriers that you encounter when transitioning from detention to treatment, something that we might want to address.
There we go. Sorry about that. One of the barriers, unfortunately, and I want to say nature of charges can be an issue with providing a program. And a frequent one that comes up are violent charges, batteries, even sometimes domestics, we have a lot more felony offenders in our facility than we've had before, even when the unit was first developed. But we do run into problems with certain programs that are unable to take people based on violent charges, which could be BDW, battery with a deadly weapon, assault with a deadly weapon, battery with substantial bodily harm. And some of those serious offenses, it is difficult. And it's becoming increasingly more difficult, especially with our SMI or severe mental health or mental impairment patients and subjects we have in our facility who have committed those crimes, not just because of their substance abuse disorder, which tends to go hand in hand with a lot of the mental health issues, but has resulted in more violent crimes, and finding programs that can take them is getting increasingly more difficult. We discuss with the attorneys, both from the public defender side and the prosecuting attorneys, and we have a good working relationship with both to try to see what's the best course of action to take based on those charges, and if there are any changes that frequently do happen when they come in here. But I want to say that's one of the bigger ones that I run into, because usually with getting the Medicaid and either the grant funding, it's not as difficult as just accepting the folks into their programs. So we're working on it, and we understand we're evolving and we're changing. and the programs are usually fairly receptive. But unless you can think of something else, Mark, I want to say that's the most frequent issue we have with the programs and many of our inmates that are trying to find help.
Yeah, Deputy Mark Kester again, thank you, sir. I would definitely agree with the mental health as being one of the major contributing factors. We're able to, with our mental health staff here, with our psych doctor and our psych nurses and our director of mental health, for the most case, we're able to get people the best off that they've been in a substantial period of time. We're able to stabilize, we're able to work with them. We're able to build that rapport with them, but ultimately it's up to them to continue with that mental health treatment. And ultimately, some of the programs have there's some hurdles that we have to overcome with some of the programs that are able to provide that intensive case management and that intensive mental health treatment, because they're primarily the transitional living, the work programs, the substance abuse programs. Mental health has become such a significant amount of our population, where we have an entire mental health team and discharge planner that is solely dedicated to transitioning our mental health population back to the community, not only for people that have mental health issues, but also intellectual disabilities and working with caseworkers and assisted outpatient treatment. And there's so many services that are available to them. So I think where we've started bridging that gap is now that the mental health providers are aware of what we're able to do within the community, we'll actually have the caseworkers and the mental health places reach out directly to us, where we're able to work with the courts and the judges and say, we have a direct transport for this individual where we can continue their care and services once they're in the community, to ensure that gap doesn't get wider once they get out there, because it's so hard to get people to stay established with their treatment and services, that we don't want that going away simply because they're, happen to be incarcerated for a trespassing or a simple misdemeanor, where the courts are more inclined to now work with us and get those people out of our custody and back into the appropriate facilities.
Hope
Thank
that
you for
answers your question, Gina.
Yes, it does. Thank you.
You're very welcome. Anyone else have any additional questions for myself, Mark Ray Kester, or Sergeant Walker?
I'll jump in if nobody else has any questions. Okay, thank you so much for those presentations. I wanted to clarify something that I heard you say, that you had 4 overdoses, one sadly that ended fatally, and that you are working to screen, and the extensive list of safeguards that you put in place was impressive, to screen for fentanyl coming in. And so considering all the measures that you're taking, from, searches to heat scans to everything else, have you identified how it's making its way in and what more could be done?
Sergeant Jason Walker, I'll just throw this out without giving too many specifics and details. We have changed our inmate mail program. Now everything is coming in the form of a scan. There is no more paper documentation, as something may have been attached to a stamp, without giving too much detail to that.
Sure, I
So
understand.
we are more proactive approach to being a reactive. And I think that getting rid of the paper mail, I think that was something that, because it's always come in, that way is always the right way. And now what we're doing is scanning that mail at face value and sending it to our detainees just in the form of electronic, to hopefully prohibit another instance in that. And it's only a matter of time when we'll come up with another proactive approach based on a reaction that we run into with 1,200 inmates. Every day is a different day.
I can appreciate that for sure. I had 2 more questions. You mentioned that, Deputy Kester, that 50% of the inmates that you have currently have some mental health needs. What percentage would you say have substance use needs as well, or are currently under, are currently under the influence or battling a substance use disorder?
Deputy Mark Kester, again, thank you. I don't know exact numbers or percentages, but I would say that the percentage would be fairly high. 90% or more would have some kind of chemical dependency or substance use disorder as well as mental health. We have a lot of drug-induced psychosis, a lot of individuals that are screened for mental health are also screened for urinary analysis and will come up positive for various controlled substances. I think our mental health population right now, so looking from March, because our data is always a little bit farther behind because we have to collect the numbers, our March numbers were 492, so nearly 500 people were being seen for mental health. Of that, it doesn't mean that every single one of those 500 people is not med compliant, is not unpredictable or anything like that. We have a specific mental health unit that nearly 150 to 180 are unmedicated, violent, unpredictable individuals. But for the vast majority of our mental health, we're able to stabilize, we're able to provide medication and mental health services. And then that would potentially allow them to proactively engage in treatment and services upon release. So ultimately, while we hold a very significant amount of our mental health population, just to put it in comparison, NAMS, the mental health hospital, Deanie Townsend, has 15 beds. 15 beds for their mental health hospital. In conjunction, we have 180 that are severely mentally ill that are unmedicated and violent. So we house the largest amount of our mental health population is here in our care and custody. Another huge contributor to that is the addiction and substance use disorder in conjunction with that mental health. Anybody who's been here for a period of time, I've been here a little over 15 years now. We've seen people that started off somewhat compliant, somewhat able to work with us. And then over the years of being on and off again, mental health medications, on and off again of substances, it just deteriorates their mental health even worse.
Oh, it's sobering. Sorry, may not have been the right word, but shocking to hear those statistics. 90% or more is substance related to some extent. And so it goes back to the slide that Christine Payson addressed in the overdose response team. And just one of the goals is to reduce drug availability. And my last question has to do with the fentanyl issue as well. You mentioned that was one of the recommendations that you would make. Do you have specific language or anything that you could potentially share with us at some point in regards to what your recommendation would be? And knowing that fentanyl is not the only substance out there, but anything in regards to reducing the amounts that are in our community, so that we can then get to the job, which is also still overwhelming, of making sure that we address those with treatment options. And so any specific recommendations you're ready to bring forward today or would like to share with our subcommittee in the near future?
And Sergeant Walker, I'm not sure if you might have a little bit more that you could share, expand on in regards to that.
Nothing on the specific language yet. With the Nevada Sheriffs and Chiefs, I sit on another interim judicial committee, and that is a hot topic. I don't have any specifics right now, but I think that's be something that would be coming up in the future.
Okay, thank you. And before I forget, one other question, and then I'll wrap us up unless there's any more questions to move into the recommendations discussion. Could you tell us, and I missed this in I think both the presentations, but do you have the ratio of men to women, male to females, in terms of housing, and then also specific to these mental health and substance use questions that we were asking?
Deputy Mark Kester again. So just some brief numbers that I was pulling from earlier as far as our breakdown. In December, just detention services, as far as the non-court ordered side, we had 22 males self-refer, and then we had 9 females. The month following that, we were at 26 for males, 13 for females. The month following that, it was almost an even split of 14 and 13. And then the following months, we were looking at 24 for males and 21 for females. So it's a pretty even split. And that's even with our male population right now being nearly, let's call it 900 or so of our 1,200. We only have between 200 to 300 females in custody. That's anything from general population to mental health and administrative status. So out of our 16 housing units that we currently have active, we only have 2 housing units that are solely dedicated to females. So the vast majority of our population currently is our male population.
Okay, and if I am hearing your math correctly, we're seeing a higher percentage of the females taking advantage of the self-referred programs proportionately to the number of males in.
Yeah, through the referral process. So we don't really, I didn't pull the court ordered side. Let me see if the court ordered. So for December, we were looking at 27 males to 7 females, 11 males to 5 females. We were split 8 and 8, and then male 15, and then female for 7. So the court ordered has a better kind of breakdown as far as, you know, a higher number of males to a lower number of females, which is proportionate to what our population is. But I would definitely say that females tend to be more willingly to engage in services and ask for assistance, and compared to our male population. So in order to kind of break some of that down, we call them walk and talks. We bring in peer-based counseling groups. We bring in managed care organizations. We bring in community providers, and we'll walk to every single housing unit, male or female, to say these are services that are provided in the community. You don't have to necessarily be court ordered. You can ask for court assistance. You can ask for your attorney or public defender. But if you just are sick and tired of being sick and tired and you want to be done and you want to come and ask for services, you can do it just by submitting a piece of paper. You don't have to, you know, ask for assistance in front of anybody else. So we're trying to be more proactive, engaging all of our population with the same services.
Okay. Thank you for that. I think that is very important to understand those barriers, as Gina pointed out, asking what are some of our barriers to treatment and what are some of the underlying factors, and it does help to break down some of those gender differentials as well. Do any other members have any questions? Okay, well, thank you. You did a great job. I appreciate that you helped paint a picture for us of both the treatment and the you know, just and the enforcement side, to be able to really truly find ways to help individuals so that we do reduce recidivism. We do help them from deteriorating in that one circumstance that you pointed out, where the last thing any of us want to see is people continuing to come back and each time worse, and really help them to get back out into the community and get back up into their lives and get the help that they need, so that they just can flourish personally and not need to interact with the criminal justice system, but then also identifying the tools that you need in order to make sure that we are reducing the presence of these toxic substances that are harming our population and our communities. And so I look forward to seeing those recommendations as soon as you have those available, and please keep an open line of communication with myself and any member of this subcommittee. And with that, we're going to close out this portion. If I'm correct, Crystal, we have no more presenters. Okay, so thank you all for presenting. You're welcome to stay on the line. And we are going to move on to agenda item number 5, which is to review the subcommittee recommendations. And just a reminder to all of our members, as well as anybody who is watching in the public, that we will have a standing agenda item for recommendations. And the work in between these meetings consists of our homework as members of the subcommittee is to listen to these subject matter experts and then continue to do research in our own fields of expertise, as well as whatever's out there available nationally, internationally, in other jurisdictions, and then here in the state of Nevada. And based on evidence-based data and best practices, we want to be, I'm not going to say it's a competition of our subcommittee versus the other subcommittees, because I want all subcommittees to give really great recommendations, but I want to feel really proud of the ones that we produce. So we will submit recommendations to the Excel spreadsheet, the form that I believe Crystal's about to bring up, and in between meetings, and discuss any recommendations that have come in. And then we also have the ability to add them right here live. And if out of our discussion, and then finalize and revise them in between meetings until we come up with our final recommendations that we will then approve as a subcommittee and present to the working group as a whole. So Crystal, with that, let me ask you, do we have any recommendations that have come in before this meeting to consider? We'll start with those and then see if we want to add any from today's discussion or table them for next time.
We do. So the document already includes recommendations that came out of February and March interim health committee. So you'll see those in there. But I think given your direction, Assemblywoman Toles, the newer recommendations that we received between our last meeting and this meeting are those that you saw in Christine Payson's presentation, as well as recommendations from Shayla Holmes, our member. And so I can scroll to anywhere you'd like to go for discussion.
Okay, let's start with the ones from Christine Payson, since we had a presentation on that. And Christine, do you want to briefly, I know you already walked us through when you gave the presentation earlier, but just walk us through what we see before us, and then we can open it up for discussion.
Okay, I couldn't hear exactly what we see where up on the form.
Correct. Just to review the recommendations that have made it officially into our form for consideration.
Okay, so the funding for an independent medical examiner to produce a report that verifies the specific cause of death in overdose cases where the source of the drug supply has been identified and can be prosecuted. Do I need to explain that again, or does anyone have any questions on that?
No, I think just pointing out that in the third column here, it points out which portions of our requirements for this committee this satisfies, and then also including special populations, the justification that the DA wants these causation experts to provide the reports before they'll go forward with prosecution, particularly in cases where there are polydrugs in the victim's system. Any questions from the members of the committee or any discussion about whether or not we want to keep this? We're not making any final decisions at this point. The main decision, I think, would be to keep it as is, to add any comments or feedback to consider amending that recommendation, or if we do not see initial support as a subcommittee for this recommendation, have discussion about whether or not we should eliminate it. So I'll open it up to the members of the committee.
I support the recommendation.
As is. Okay, so no comments or questions or additions or amendments, just as is. Okay. Yes, Dr. Woodard.
Oh, one question. I'm
Oh,
sorry. Is
Yep.
it one? How many independent medical examiners? The number, would it be one?
That's unknown
Okay.
how many it would take. I guess it would probably start with one or two, and then depending on the caseload. But that's me just guessing. I don't know that for sure.
Okay.
Okay. So question as of right now, starting with one and then maybe more based on the need. Do we know that there will be a fiscal note? Do we have the numbers on exactly what that fiscal note would be? An estimate? Ms.
I was
Payson?
told that each independent report can cost up to $10,000.
Okay, so that's for the cost of the report, but for the actual position that we're looking to fill.
Don't know, but I can find out.
Okay. So may I recommend, and Dr. Woodard, I haven't forgotten about you, may I recommend that we get some more specific data on what we think that budgetary request might be, and also what the recommendation of this subcommittee could be in regards to what the appropriate funding source for that would be. Would that be a request for the governor's office, budget office, to include in the next biennial budget? Or would this be something that could be specifically funded through grants or through the opioid settlement dollars? And so if we could get a little bit more clarification on that, Ms. Payson, I think that would be helpful in finalizing that recommendation. Let me pass over to Dr. Woodard. If Dr. Woodard, you have some additional questions or comments.
I do. Thank you, Chair. Stephanie Woodard for the record. So it leads back to Gina's question earlier around how many. I just want to make sure that we're also thinking about statewide-ness. I know that there are considerable challenges in our rural communities. Oftentimes it's the sheriff that's making the cause of death determination, so that we can make sure that we are applying this kind of resource equitably across the state.
Okay, thank you for that comment. I am conscious of the time. It is 1:50, so let me go ahead and take a look at some of these other ones a little bit more quickly, because I want to make sure that we give Shayla some time to discuss hers. So the next recommendations from Christine Payson, we obviously saw in the presentation. So funding for the ODMAP system. Was there any urgent comments or questions while we have Christine on the line? I do see that it was identified as urgent, and once again, in the same way that we would want any specific amounts, the more specific our requests I have found, the more successful we are at being able to get hopefully potential buy-in. And the earlier and the more specific is always helpful. It seemed no other questions or comments. Moving on to the last part, additional police for the overdose response teams. And I asked questions about that as well. How many do we have today? How many do we think we need? How does it compare to other similar sized jurisdictions? And then I would add to that Dr. Woodard's charge that I agree with, that how do we make sure that we're keeping this statewide, and do any of these recommendations, how do they specifically apply to rural communities, Washoe and Park? And Crystal, I'm glad for your sake that this is being recorded so that you can go back, because I know I threw a lot into that little comment. Any other comments on that particular item? Nope, okay. And then we heard some, definitely a theme in regards to AB 236 and the recommendation to revisit fentanyl. I did ask our presenters if they could come back to us with any specific language in conjunction with Dr. Woodard, as in regards to what the recommended levels are. I know that we did hear that recommending that we go back to the previous levels for fentanyl in particular was one recommendation, but we want to just seek clarity from our presenters today before I think we land on that final recommendation. But any other questions or comments? Nope. Okay, then Shayla, thank you for submitting some recommendations. Shayla, would you like to briefly give us a quick overview? We are getting a little bit close to the end of our time here, on what your recommendations are for us to consider.
Sure. I haven't seen it in this format since submitting it on the survey, and my research document looks drastically different. So as long as you're willing to scroll down for me. I think the first one or this expungement program. So just in doing some research, utilizing some peer-reviewed journals, evidence-based articles, and then it just aligns with what we see in the rural communities as far as how we utilize peers and how we really help respond as a community to individuals living with substance use disorder. And what we hear frequently and what we see as issues in employing peers within our community programs is getting folks back on their feet quickly is hard. So an expungement program that helps folks work through how they can seal their records, how they can close those criminal charges quicker so they can become stable faster and put that part of their recovery behind them so they can continue in that positive part of recovery for going forward. So I think if there's anything that we can do to create an expungement program, clearly with some identified requirements around it, as far as low-level offenses, not these high-level drug trafficking offenses that we heard Ms. Payson sharing about, but individuals that are truly in recovery and working towards stable lives, anything we can do to help them expunge those records so they can maintain stability faster, I think the better off our communities would be. I don't know if there's any other conversation on that one, or if you want me to just work on down the list.
Any questions or comments, members?
I'd be in support of that for sure. Gina Flores O'Toole, sorry.
And just to thank you. So just to be clear, there is a BDR forthcoming, and the recommendation would be that the subcommittee would support that effort. Okay, I see Shayla shaking her head for the record. All right, and the next recommendation, Shayla?
This next one, very similar to what Ms. Payson presented, however, with a slightly different approach. So we do currently have mobile outreach safety teams. I know Dr. Woodard shared on this during her last presentation as well, a lot of the things that have been put together. ACT teams, lead teams, these teams that respond to behavioral health crises and throughout Nevada, but they're really valued, particularly in the rural communities, which I represent. And there's a lot of research showing that these teams or similar types of teams being utilized for targeted overdose or suspected overdose response has great outcomes in regards to making connections to behavioral health services, whether it be inpatient, outpatient. We know that a lot of folks that take an EMS ride in to a hospital setting or an inpatient setting due to potential overdose don't always necessarily have a strong discharge plan on the way out or a bed to go to. So we don't always have beds available, or individuals aren't always willing to go into beds. So having a team like this that is dispatched upon discharge from an inpatient setting when there's a suspected overdose or a valid, substantiated overdose, for these teams to go out and meet with the folks in their community, connect them to community resources, and really help ensure that they don't have a repeat situation as far as overdose goes. And then also, I'm not sure how this could be potentially a midline solution to what that targeted opioid outreach team might look like as far as investigative goes, and what that bridge could potentially be as far as how do we avoid the Good Samaritan law piece, because these co-responder teams could go out with the purpose for resource connection and preventing future or further overdose or substance use disorder, and getting folks connected while potentially being able to identify, additional information as far as any law enforcement piece might be. But I do believe that these teams have a great ability to prevent and connect folks to the right resources in their communities when they're experiencing substance use disorder.
Thank you, Shayla. And just want to point out that you have some references to pilot programs, and we are always going to be looking, since this is an ongoing committee, we are always going to be looking for subject matter experts, and at some point bringing in perhaps some of these out-of-state best practices models that we could take a look at would make for some good subject matter expert presentations in the future. So always keep that in mind for you or any of the other members of this subcommittee to make those recommendations for any model programs you'd like to see us consider, to make those recommendations to Crystal. We are getting close on time. Dr. Woodard, I do see your hand raised though, if you want to quickly ask your question.
Sure. So Stephanie Woodard, for the record, I was just going to make a comment. We do actually have some teams that we've launched in Nevada that I think would be very valuable for subject matter expertise on what some of the issues and barriers have been to being able to take some of these programs to scale.
Wonderful. And then how many more recommendations, Shayla, do we have? Because I don't have the ability to scroll down on the entire form.
I think just a couple within ours.
Okay, for the
There was
sake
some
of
that Crystal
time,
decided were better fit for a different section, so I'm not too sure how many made it on this list.
got it. Okay, so we have the
Two more.
nalox. Pardon?
There's 2 more here, Shayla, and I was gonna add yours back over, but I'll email you about that separately.
No worries.
So briefly, I see that we have nalox boxes and being made available at public locations. Okay, and then I think that would be a good, more in-depth conversation to have. And then we see creating community higher education partnerships with the purpose of having interprofessional continuing medical education sessions. And so for the sake of time, I'd like to give us a little more time to discuss these, Shayla, in our next time meeting. And I think that also in August, when we have the deeper dive discussion on the Good Samaritan law and some of those interactions, that will be a good time to dive deeper into these recommendations. We've also scheduled a little bit more time for discussion as we get closer to our deadline to vote on and take action. So if I could just ask members, if you have specific questions for Shayla to consider, or any of our members of the subcommittee to consider, to please send them into Crystal. You do have a copy of that Excel spreadsheet, so you can make a copy and insert your comments and questions directly into that spreadsheet, send it back to Crystal, and she will then populate all of ours into one consolidated form for an evolving document to continue to discuss in the future. And then Shayla, you'll also, and for any other members, you'll also have a chance to see each other's questions and comments. So before our next meeting, so you can prepare those answers as well, and we can have more discussion. And you can also submit it via the survey link as well. Thanks for that reminder.
Chair Toles,
So, yes.
just a note with regard to sharing information ahead of meetings, any new information they can't. So what is part of the public meeting, they can obviously review, but as they're making their comments between meetings, that won't be public until the public meeting.
Thank you so much for that clarification. Yeah, we want to make sure that that's clear for the public watching and for our records. So with that, unless there's anything urgent, if we can move to our last agenda item before adjournment, and that is public comment. Shayla, are you good with that? Okay.
Absolutely.
Okay, thank you so much. And so we do have, I see one hand raised for public comments, and just a reminder to the public that we do limit public comment to 3 minutes, and we will not be taking any action on public comment, but we appreciate it, your input. So let me start with Rhonda Fairchild, I see with your hand raised.
Hi, my name is Rhonda Fairchild, for the record. I'm with Behavioral Health Group, formerly Center for Behavioral Health. And I wanted to comment that we do jail dosing at Center for Behavioral Health for the southern area, in the southern area. And about 95% of all of the clients that we jail dose return back to their home clinics for continued care. So my comment is I love that idea, you know, of them doing that. Sergeant Christensen and the Kesters, are they brothers? The Kester brothers, I want to say, or cousins, or whatever they are. And then on your spreadsheet, under special populations, line 33, it says people who injected drugs, but it should say people who injected illicit drugs, because people who inject insulin aren't necessarily in this population. And then also, because Lisa Lee isn't on this call, I'd like to say it's substance use, not abuse. And that's all I have. Thank you.
Thank you so much, Rhonda. I so appreciate you being on this call and your insight and expertise. Thank you. Do we have anyone else on Zoom? Anyone on the phone? Feel free to unmute yourself and announce yourself. Give you about 20 more seconds while we wait. All right, I don't hear anyone. So with that, just want to thank everyone for all the members. Thank you so much for participating, thinking, listening, commenting, recommending, asking your questions, taking on this work together. Thank you, community partners, members of the public watching. We appreciate you as well. And we look forward to our next meeting as a working group in June, and then as a subcommittee in July. So unless there's any other questions or comments, with that, I'd like to adjourn this meeting. Thank you so much and have a wonderful rest of your chilly May day. Thanks, Crystal. Thanks, Laura.
Thank you.